invitation and the introduction. Well, I have 15 minutes to talk about Adnexal masses in children and adolescents. It's quite a huge subject, a little bit difficult to treat in such brief time, but I will try. Starting to say that ovarian masses are the most abdominal masses in pediatric population. They represent almost 80% in this area. Ovarian masses can occur in all age, but their incidence, clinical presentation, and histological distribution vary among different age groups. Ovarian masses is reported in 3 to 8 of children and adolescents, and an adnexal mass is account for 1 to 2% of all childhood cancer. Pediatric patients with an ovarian mass have a long life expectancy after treatment. Preservation of gonal function is of paramount importance, not only for fertility maintenance, but also for the natural progression of puberty. During the evaluation of an ovarian mass, the most important objective is to assess the likelihood of malignancy, since the management of benign and malignant lesion is essentially different. Management of ovarian mass in children and adolescents should be curative, feasible, function-preserving, and minimally invasion achieved with laparoscopy, ovarian-sparing surgery. Let's enter to the subject and start by saying that 50%, more than 1/2 of ovarian masses, are arising from functional cysts. These cysts have a bimodal distribution with 2 incidence peaks. One in the antenatal and neonatal period, according to the hyperstimulation by maternal hormones, and also in peripuberty period. Just remember 2 important facts considering pediatric population. First of all, that purely cystic fluid is presumed benign, and it becomes organic if they persist after 6 months. Second, and important information, is that the cutoff considered for adult population, which is about 3 centimeters, is less in children, and we consider that the cyst is organic since it measures 1 centimeters. The other 50% are represented in 80% of cases by benign tumor and in 20% by malignant. We are going to treat this 20%. In these 20%, you can have germ cell tumors that are the most representative tumor in this group. Stromal tumor represent 10 to 20%. Epithelial tumor are more frequent in adolescent and young adult and represent 15 to 20%. And other tumor, also called miscellaneous tumor, represent only 5%. Ovarian masses diagnosis is based on clinical information, imaging, and serum marker. US is classically the first examination to be performed. It's easy, with no radiation, no sedation, and you can do it on your own rhythm and the rhythm of the child. I may give you just one advice. Remember that the cold gel, when you touch the belly of the baby, he wants to pie. So my advice is just to start always by exploring the pelvic area. Remember this normal aspect. It's very important. Before 6 months, impregnation with maternal hormone gives a special aspect to the uterus. It may resemble a little bit to the adult form that you know and appears as tubular, and you can see the line hyperechoic like we can see in adults. From 6 months to more or less 8 years, the uterus becomes smaller, less than 3 centimeters. It's usually like a pear form with a body smaller than the cervix. Ovaries are less than 2.5 cc, seed from small follicle with strictly fluid content. While the puberty approach, you can see little by little modification in the shape of uterus, and the body of the uterus becomes bigger than the cervix, and you start to see the hyperechoic center related to development of the endometrium tissue. These are signs of estrogen impregnation that you should always search when you are going to explore or when you are going to perform an ecography for children presenting with an adnexal mass or an ovary mass. Here is some example you can see here in the young patient with this small uterus tubular. Small ovary with some follicular structure. In the other side, you can see the adult form that you are used to see. This is a typically pre-pubertal aspect of ovary. And this is a post-pubertal ovary that that you see in adults. MRI is a very good technique. It may be difficult of access and needs sedation, but it's very useful, and it's clearly the second exam to be performed after ultrasound. CT is useful if we can't perform MRI. It's useful if we want to, if we are in a neoplasm situation and we want to do staging. And it's also necessary if you want to plan surgery. How to say that the mass is ovarian? We have a lot of signs in image while performing images. First of all is the nourishing artery. You localize the aorta, then the renal artery, then the gonadic artery, and you follow it until the mass. If it finishes on the mass, it means that this mass is of ovarian origin, as it is nourished by the gonadic artery. Of course, if the ovary disappears, it's also a sign. You can also see a peripheral ovarian parenchyma with cystic structure on it, which represent the follicle, and this is a sign of an ovarian origin. Generally, the mass is usually pelvic and posterior, especially when if it's small of middle side, but when it's bigger, it's classically abdominopelvic, and you lose this this classical position of the mass. It can be interior, left, right. You can't localize it. When you say that the mass is suspicious of malignity, according to me, if you have just to remember two signs, remember those two, sorry. Solid or presence of solid component, and if the mass is large, bigger than 8 to 10 centimeters. These are the most constant signs that may suggest malignity, and they may push you to go further in your explanation. Talking now about a very important part, that is serum marker. You have to know that when we are in multidisciplinary meeting and we are discussing ovarian mass, I always refuse to propose a diagnosis, as the clinician didn't give me the result of the serum marker, because it's very helpful, as elevated tumor marker can really help you to think and even to search for particular sign. They may be elevated by the presence of the malignancy due to itself production, or by normal cell in response to the neoplastic cell, and I'll give you an example. These serum markers can be useful for diagnostic, but also for follow-up. But if they are negative, does it mean that it's not this kind of tumor? Because there is always exception. Let's see what's going on with germ cell tumors. All start with totipotent germ cells. If they are undifferentiated, we have a dysgerminoma, also called seminoma. If there is a tissular differentiation, it can be embryonal or extraembryonal. If it's embryonal and the epithelioma is low differentiated and no low differentiated, we have an embryonic carcinoma. If the undifferentiation go into the way of ectoderm, mesoderm, endoderm, we have teratoma. Teratoma can be mature or immature. If it's extraembryonal, it goes in the way of yolk sac, and then we have yolk sac tumor, or in the trophoblastic tissue, and we have choriocarcinoma. Remember this. For dysgerminoma, it's HCG with a very low rate. We can also have LDH, but it's not specific. For embryonic carcinoma, we have alpha-fetoprotein and SCG, but with a low rate. For teratoma, when it's immature, we can have either nothing or a low rate of alpha-fetoprotein rate. For mature teratoma, and this is a very important message, there is no secretion. And any of the markers should be positive. For yolk sac tumor, alpha-fetoprotein is high level. For choriocarcinoma, it's HCG. I show you some example here of a mature teratoma, and in all my example, I'll try just to emphasize what seems important for me. See the middle image of the upper line. You can see here there in the image, the cystic image, there is a posterior acoustic shadowing. This is a source of mistaken because this shadowing, due to the component in the cyst, make you not see what there is behind, and sometimes you'll be mistaken the mass, considering that it's bowel and or gas or fecal, and we conclude wrongly that there is no mass and it's normal. You can see here in the CT scan and the MRI that there is calcification and fat, and remember that the presence of calcification and fat doesn't mean that it's mature. Typical immature teratoma can present with calcification and fat. Another example here, especially, I like this one because you can see a good correlation between echoic images and clinical images showing the Rokitansky nodule in the wall of the cyst. These are the signs with which you suspect malignity. If the tumor is larger than 8 centimeters, if it's palpable, if it's solid or necrosis predominant, if there is peritoneal effusion, even if there is fat or calcification, or if alpha-fetoprotein is high. If you have any of these signs, start thinking that it's not just mature teratoma, but that can be immature teratoma. There's another example of 14-year-old girl presenting with a huge mass, with a large necrosis. Clearly, we have here beta HCG increased and LDH. And if you remember my picture of the beginning, you see that we have already our diagnosis, and it is a dysgerminoma. And here you can see the piece of surgery. Another example, 10-year-old girl, bicomponent mass, cystic and solid, increased rate of alpha-fetoprotein. If I ask you for the diagnosis, you ask me for serum marker, and you are right. It was an increased alpha-fetoprotein, right? And we concluded to the diagnosis of Yolk sac tumor. Let's talk about tumor now. They represent the sex cord cells arising from granulosa and Sertoli cells, around 10 to 20% of all pediatric ovarian neoplasm. 70% of them are represented by the juvenile granulosa cell tumors, which is subdivided into adult and juvenile types. Generally, it's the most frequent sex cord cell in patients less than 20 years old, and which very important to notice that you have clearly signs of estrogen impregnation, which is very useful in pre-pubertal period. The serum marker of this tumor is inhibin. You can also have Sertoli Leydig cell tumors with a median age of 14, 30% of androgen secretion, which means clinically viralization. And we can also have in this group fibroma and fibroticoma, but they're really rare in pediatric and adolescent, and usually seen after 13 years old. Here is two examples, 3 years old, consulting for abdominal distension with the breast rod for a few weeks and spotting, and you can see the mass with a cystic component. This patient had surgery and it concluded to juvenile granulosa cell tumor. Another example, see the mass here. It was an old case, but I wanted to show you that although she was 4 years old, you can see that her uterus resembled to an adult one. Again, here it was a juvenile granulosa cell tumor. Epithelial tumors are rare in children and account for only 15 to 20%. They occur almost exclusively after menarche and seen in old, adolescent, and young women. In children, they are classically benign. Here is an example of an 11-year-old with normal blood marker, and this girl was operated and it was a mucinous cystadenoma. To end, and to respect my time, I just want to remember you that predisposition syndrome exists and that you have to think about it in some presentation. For example, if you have a juvenile granulosa cell tumor and you have an onchondroma, you have to think about association, about cancer predisposition syndrome, in order to check your patient and to give him a special follow-up dedicated to his pathology, to his type of tumor that he can make. I will finish by saying that ovarian masses are the most frequent adnexal masses. Ovarian masses in children and adolescents range from simple functional cysts, remember that it represents 50% of all the group, to malignant neoplasm that represent only 20% of the left 50%. Germ cell tumor represent the majority of ovarian neoplasm in children and adolescents, and imaging and serum tumor marker can assist the diagnosis process and can assist you in your démarche. I will finish in Arabic and tell you that it's هذه أول مرة أتي فيها لمصر. وقبل المرة دي كانت لي علاقة مع مصر كانت مبنية على الحب وعلى الخيال، والآن علاقتي مع مصر مبنية على الحب، على الصداقة وعلى الواقع. كل الكلمات لن تكفي لأشكركم على الدعوة وعلى حسن الاستقبال، ولكن ألف شكر.
Thank you, Dr. Moalla.